All right, welcome to Alabama EMS Challenge. We're down at Prattville. Thank you, Prattville, for hosting us. I'd like to thank Alabama Fire College for also supporting us and sending us this way and being a sponsor. I'm Will Ferguson, if you've not been here before, and we're going to have myself and then Dr. Rose will be here at 11, talk about chest trauma, and we're going to try this high-tech board. I'm one of the ER docs down at UAB. I'm the BRIMS medical director as well. I reached out to the state. I think someone from the office may be here as well, Office of EMS, this afternoon to kind of help out as well, but we'll see. But EMS Challenge was started several years ago to basically promote Con Ed. My background is EMS, and it seemed like, 30 years ago, there was always physicians involved in pre-hospital care. That's kind of waxed and waned a little bit over the years, but I don't see as many docs trying to get involved. So one of the things I'm trying to do is push out physician-led Con Ed. This stuff should be practical. There are things you can learn in the textbooks, things you can learn in the field, and then you need to kind of understand what we do in the hospital and put all this in kind of a real-time, practical, common sense approach, okay? Not so much academic-ish. And that's the goal of these classes. If I say anything that sounds inappropriate or weird, raise your hands, let me know, and I'll correct that, okay? Fair enough. I got smiles that time, thank you. All right, for you Con Ed, there'll be in the chat box for you guys online a link to do a survey. If you're here, you can scan the QR code on the wall, and that'll get your certificate sent to you. You can also email alabamaemschallenge@gmail.com. If you're going to do the email version, do that by this afternoon, please, so we can get these out to you. National Registry says that you can use any Con Ed for this cycle. If you're here now participating, this is live Con Ed. It's not non-distributive. It is non-distributive, so you can get credit for this like a live class. We also have the YouTube channel. You can watch that and get Con Ed through this cycle as well. Upcoming stuff will be in Decatur in April, be in Aniana in May. CCTMC is a critical care transport medical conference. It's a national conference put on for rotor wing and critical care programs. It's going to be in Orange Beach this year. That's a national thing, really close at the on the beach for us. So if you got a chance to get there, it's in May. You ought to do that. High quality Con Ed, national speakers in our back door. We'll be in Mobile in June, and then we're still at Centerpoint Fire Department on the second Wednesday of each month doing Con Ed for us. So the first hour, I try to do some 12-lead reviews. I also talk about some cases, things that kind of come up in the past couple of weeks that I've seen in the ER or complaints I've heard. So I want to kind of talk about ketamine. Are y'all using ketamine down here? Any? Yes, look at those smiles. All right. No one's personally using ketamine though, correct? All right, just to clarify. Great, not right now. So ketamine came out a couple of years ago through the state, which is very exciting. There's some hospitals that I work in Alabama that as an ER physician, I cannot even get ketamine. If I want ketamine, I have to walk down to the pharmacy, sign a form, give a drop of blood and my credit card, and then take it back to use for the patient, right? So the fact that we have it in pre-hospital is exciting, very useful drug. However, there are some concerns I want to talk about, all right? So ketamine, it is a rapidly acting general anesthetic. So the places where I work where I can't get it is because anesthesia has a strong hold on that drug. It's used in the operating room. For years it's been used there. There have been a lot of military studies showing it's great for trauma and sedation on young healthy folks, and that's why it's moving down into EMS for pain management and excited delirium. But it basically blocks glutamate in the brain, and glutamate excites cells, so it makes people chillax a little bit, okay? You can get some bad effects, sort of like we talked about LSD years ago in the 70s. People did that. You get a good trip or a bad trip. Some folks don't appreciate ketamine and they start having a bad trip, getting more psychotic and not really relaxed. Those folks, you got to chillax them with some benzodiazepines. And it's also fairly useful for pain control. I'm not a big component for pain control at this point in the game, but it's out there. Side effects with ketamine, we kind of talked about as a bad trip. It's also known as the K-hole. Some people get increased salivation and the laryngeal spasm. Years ago, when I would sedate kids for a procedure and I give IM ketamine, I always gave them atropine because atropine dries you up. So when it gets so full of secretions. In reality, it's not so much that you can't protect the airway. Those folks, a little bit of suction works fine, not a big deal. I don't do that so much anymore, but you can get it. You can also get some laryngeal spasm. You might get a little bit of stridor post-ketamine use. Don't freak out. It's not an allergic reaction. All I need is a little bit of airway management, sit them up a little bit, suction the airway, and a little bit of positive pressure ventilation for a few minutes, and that laryngeal spasm will go away. Any drug we give in America except for Zofran will cause vomiting, right? Ketamine also will cause you to get elevated blood pressure and increase your heart rate. So it is useful for intubating people for sedation, pain control, and folks who are hypotensive because you're not going to make them more hypotensive. Pretty good stuff. Sometimes you see nystagmus. They get tonic-clonic jerking. The eyes kind of trip, look like they're pinging for you. That's common. Years ago, we said we could not use ketamine if someone had a head injury because it increases intracranial pressure, can make brain damage worse, and that is false. We use it all the time in head injuries. There are pretty good studies out there that show that's wrong, okay? The only true contraindication to ketamine is someone who's had an adverse reaction to it, someone who has an allergic reaction, someone who's had anaphylaxis. And where you work and where I work, we're not going to find that out. If we're giving somebody ketamine, they're not going to be able to answer that question for us, right? So, obviously, it causes respiratory depression. If they're already on the street, you're giving it for excited delirium because they're agitated. They probably already smoked a little weed, done some spice, maybe some alcohol. So get ready to manage their airways, okay? Anybody that gets ketamine, once they get ketamine and they're chillaxed for you, they need to be on the pulse ox at least. Cardiac monitor, if you got it, end-tidal CO2. Do y'all have waveform capnography, nasal cannula down here? Yeah, that is like cheating. It's a great way to make sure your patient is breathing and ventilating well. Remember, ketamine is a short-acting analgesic and sedative. It may have to be redosed if you got long transport times, okay? So ketamine, great drug. How often y'all using it down here? Pretty good bit. Y'all use it for pain or just for excited delirium? For both. Okay, cool. All right. So excited delirium, when you should use ketamine, the high dose, the 4 mg per kilogram, which is kind of high, but excited delirium is a controversial topic. We kind of put a lot of things into that conglomerate. What's going on? My thoughts on this is the person who is butt naked, beating up 3 cops, and you're called to the scene. Those are folks with excited delirium or agitated delirium, right? If you look, do a quick search of the literature, there's about 250 deaths a year due to excited delirium. A lot of these are in police custody because those folks usually are not behaving well. So law enforcement shows up. It's probably higher than that. It's probably 800 or more. And there are probably some folks out there that are dying from excited delirium that we don't even understand why or don't do an autopsy. So excited delirium, it's a catchphrase for a lot of things. We usually see psychosis, right? So we see the patient who has a history of schizophrenia or just smoked some spice, shot up some meth, and now they're completely crazy, violent, combative. But other folks can have it as well. You can get this from alcohol use. You can get it from alcohol withdrawal. So the person who's drank alcohol for the past 20 years, they're doing, a case a day, and now they stopped. 12 hours later, they get a little bit confused, demented, they get pretty agitated. The difference is, most of the time, these folks you can restrain without medications. They usually wear out on you. Same thing, people who are hypoglycemic sometimes get altered, confused, seizure-like activity, get aggressive. But again, those folks eventually stop moving because they're hypoglycemic, right? And we can fix that, right? Other drugs, we already mentioned spice and meth. Cocaine is predominant as well in the South. A lot of folks smoking some crack get pretty excited. They get hypertensive, they get tachycardic, they get aggressive, all right? The problem with this, all these things, when someone who's aggressive with you, is you get this big catecholamine surge. So they have more increased epinephrine, norepinephrine, they get hypertensive, they get tachycardic. Most of these patients already have underlying health problems. So the guy who is smoking crack at 40 probably started when he was a little bit younger, right? So he's probably got health disease, heart problems, things like that. And this fast heart rate and elevated blood pressure is not good for them. And then you go and try to restrain these guys, or law enforcement shows up and they get tased. They get more of a catecholamine surge, and you're going to see these folks going into cardiac arrest. They can also have kidney issues from long-term issues. They can get rhabdomyolysis. They can get hyperkalemic, a lot of big issues. So excited delirium can be really bad for these folks. There's some other things, medical issues that are not drug or psych-related that can cause this. We call it PRESS, potentially reversible encephalopathic syndrome. Don't make me spell that. I'm from Mississippi. Those are big words. But basically, bad hypertension, the person who is normally hypertensive in the 180s to over 60s, who now is 220 over 110, and that way for a few hours. You break down this blood-brain barrier that protects the brain from normal toxins in the blood. It crosses the blood-brain barrier, and now they get confused, they get altered, they get excited. Uremia, so this is a byproduct of folks who don't have good kidney function. That can get really high and make these folks get agitated, okay? Then obviously sepsis, infection, meningitis, encephalitis, these folks can trip out and get pretty aggressive. But the most common things we're going to see in the ER pre-hospital field is the guys who are psychotic or doing the drugs, right? So this is a 6-foot male, acutely agitated, psychotic. When you approach him, he screams, kind of claws at people. He's sweaty. He appears to be responding to internal stimuli. He's got a history of events like this in the past. Does he make you uncomfortable or not uncomfortable? He makes me uncomfortable, right? Even in the ER, when I got like 8 big cops, right, I still get nervous when I see folks who are pretty agitated, right? So this guy, potentially good ketamine patient, right? Maybe a little ketamine to relax him. 6-foot male in a nursing home. When approached, he kind of screams and claws at the staff. Doesn't really walk at baseline. He's diaphoretic. He's confused. He's got a Foley bag hanging over the side of the bed rail. It's cloudy. He's had events like this in the past. Does this guy need ketamine? Good answer. No, he does not, right? Technically, he meets the state protocol, which is altered mental status, right? Yeah. So you give this guy ketamine, you relax him a little bit, scene is safe, doing a good job. You give this elderly person who is probably septic and confused ketamine, what's going to happen to them? Yeah, going to decrease his respiratory drive. He's not going to do well. He shows up to me, and now he's got nystagmus. He's altered. He's not breathing well. He buys a tube. At his age, he's not going to do good in the ICU. It'd be hard to get off the ventilator. So I've seen older folks get ketamine because staff was afraid they were going to hurt them. These folks, you can manage differently, soft restraints, maybe check an AccuCheck, give them some fluids, but do not need ketamine, right? All right, same thing with this guy. He's a great ketamine person. He looks like, never mind. All right, so what's the dose of ketamine for excited delirium? So you got that 6-foot guy going crazy, swinging at people. What are you going to give him? Perfect. Yeah, so state says 1 mg per kg IV. I'd say if you get an IV in him, he probably doesn't need ketamine, right? Because he's too chillaxed already, right? 4 mg per kilogram IM. All right, that's perfect. We're not going to talk about pain today, but so this guy's 5'6", he's 300 pounds. That's 160 kilos. So how much would he get IM? Who can do that math? Good, good. Y'all went to the same school I went to. Yeah, the whole vial, right? You pop the top and it's the whole thing, right? Yeah. So in reality, ketamine should be based on ideal body weight, okay? And the reason because of that, is if someone is 300 pounds, 5'6", versus 70 kilos, right? The fat cells in the body really don't do a lot. So they're not going to help with metabolism or things like that. So if you give them total body weight dose of ketamine, you're really going to overdose these guys, right? So there are a lot of ways to calculate ideal body weight. Formulas here from Chief Ward was a kid from the 60s, right? Way too confusing at 2 in the morning when you're tired. I kind of think of things like this. I say that I do 52 kilos at 5 foot. All right, then 2 kilos per inch in males, same thing, except 50 at 5 foot, right? So you can see that the dose, you got to do a little bit of math for this. You don't want to do total body weight because you're going to overdose these folks, right? So I kind of look at this as height-based, adult Braslow tape, and I'm getting this look from you guys right now talking about math, right? But I tell you, I also get this same look when I had a patient a couple of weeks ago that came in and got 750 milligrams of ketamine. Does that seem like an appropriate dose? No, right. 2 red flags. 1, you pop 2 bottles of ketamine, and 2, that much ketamine should kill most anybody, right? Or at least make you not move. All right. So you got to do some math with this. You know, when you think about obesity, and that's a lot of our population in the South, you want to base most of your drugs that affect respiratory drive and so forth on ideal body weight. So it's kind of height-based. You can use this formula, 52 kilograms, and then 2 per kilo. All right, you can do that. That's reasonable. There's an app you can get on your phone that you can do ideal body weight, okay? What I tell people is know what your dose would be so I know how much ketamine I would get if I was acting a fool, all right? That way, if I walk up on scene, I see somebody my height, I know what they're going to get. If they're a little bit taller, I'm going to guesstimate their height a little bit more and give them the appropriate dose. And if they're shorter, I'm going to give a smaller dose. I'm not going to look at their width or their weight, okay? Same thing, so for the guys that do critical care stuff, when you think about tidal volume, when you ventilate somebody, right? So if you got somebody who's got lungs like so, right? That's the heart. I'm a great drawer. Those are your lungs, all right? And the guy's 70 kilograms, so that's his body weight. And I ventilate him, all right? So if I got the same guy, same size lung, he's 6 foot tall, but now his body weight is 400 pounds, you still lose the same tidal volume for the same thing, for the same size patient. Same thing with ketamine, same thing with other drugs that we use in sedation in the hospital. propofol, etomidate, things like that. We don't weight base some of our antipsychotics, but the point is ketamine dosage should be ideal body weight, all right? So 5'6" male, 350 pounds, 160 kilograms. He would get 640 milligrams of ketamine if he did the 4 mg per kilo. If he did ideal body weight, he only gets 250. So that's a big freaking difference in dose, right? All right, I'm getting that blank stare again. I like this. This is good. So all that to say is I recommend either do height-based dosing, all right? Use the app, or if you don't want to do those, the other option is don't do 4 mg per kilo. Do 2 mg per kilo. The goal of ketamine is to slow them down so they don't hurt you or anybody else. The goal of ketamine is not to knock them down so much that you intubate them, okay? So a lot of ways to manage this, but just be careful. Ketamine can be overdosed pretty good. And then if you want to be gender neutral, just pick your one weight, 50 kilos, and don't do male versus female. Post-ketamine patients, the thing that's going to get people is respiratory depression, like you mentioned, all right? The actual toxic dose of ketamine that will kill you without respiratory depression is like 680 milligrams per kilogram. I hate to tell you guys that. That's a lot of ketamine, right? A lot of ketamine. The problem with ketamine is it makes people quit breathing, all right? So post-ketamine patients, they're sick patients. If you give somebody, that guy that was fighting and dancing and clawing, you give him 4 mg per kilo of ketamine. Once he chillaxes, you expose him, you get an AccuCheck, make sure he's not hypoglycemic or hyperglycemic. You look for holes, patches, tattoos, things that kind of lead you to believe underlying health problems, all right? He gets put on the cardiac monitor, he gets a SAT probe. If you have nasal capnography, use that. That's fantastic. If you don't, a SAT probe is fine. The key here is if he drops his SATs, you do not put oxygen on him, all right? Are y'all doing pre-oxygenation before you intubate here? High flow O2? Yes, no, maybe? Right. So we know from studies that you can put oxygen on somebody that's not breathing and their SATs will stay up 99, 100% for several minutes. All right. So if you got this guy that's post-ketamine that is now not breathing and he gets hypoxic and you just put oxygen on him, he's hypoxic because he's not breathing, right? So oxygen does not fix that problem. So now you got a good 8 to 10 minutes of him having great SATs before you realize, oh crap, now he's in cardiac arrest because he's hypercapnic and he wasn't breathing. So if they're hypoxic, all right, you open the airway, jaw thrust, lubricate a nasal trumpet, slide that in the nose hole, okay? If that works, great. If that doesn't work, pull out an OPA, pull out a King or an iGel, all right? Break out your BVM and ventilate them. That's how you manage hypoxia post-ketamine. And I can tell you, I've seen several cases of folks that have come in on a non-rebreather, breathing 2 times a minute with SATs 100%, heart rate 140, all right? And they're like, oh, they're fine, and they're not fine, okay? So do not be tricked. Don't be that guy. You'll feel bad about it. Remember, there's oxygenation and there's ventilation. Ventilation. It's not your word, is it? Ventilation. So if they're hypoxic, they don't get O2, they get airway management. If that doesn't fix it, they get oxygen with airway management, okay? The goal is to chillax them so they would go to the hospital with you and not get hurt, okay? If you give them too much ketamine or you give them the appropriate dose of ketamine and now they become hypoxic, they're not breathing well, you put an iGel in them, you ventilate them, they go down, you intubate them, you bag them, no harm, no foul. You address the problem. You manage the airway, okay? If you just do oxygen, if you just do that and you don't recognize the failed airway, them not breathing, somebody's gonna die. And that's very poor form, all right? Very poor form. All right. Enough on ketamine, sorry. So 12 leads. So there are a lot of blogs out there. I was actually doing a blog last night, that critical care flight paramedic blog on 12 leads, kind of looking at that stuff last night. But remember, 12 leads are a screening tool. We're not trying to be academic. We're not the cardiologist. You aren't, I'm not. Our goal is to recognize is the EKG normal, abnormal. If it's abnormal, I need to address it, okay? A lot of variants out there. You're going to see abnormal EKGs that we don't do anything with. So the goal of a 12 lead is to screen the patient, sick or not sick, STEMI, no STEMI, okay? And do I need to address those things? So I try to keep these pretty simple. I look at 12 leads and I say they're too fast or too slow. I use the rates 50 to 150, okay? Somebody at the heart rate of 60 that looks ill, I'm uncomfortable, but it's probably not cardiac in nature. Somebody at the heart rate of 30 who looks like dirt, it's probably the heart rate, right? I'm gonna start jumping on them, managing them. People that we see in the pre-hospital environment are always tachycardic, Okay, you just show up with the big red trucks, lights and sirens, something just happened, then we tachycardic. But if the rates are greater than 140 or 150, you should be concerned there's some kind of cardiac issue going on or some kind of traumatic event and they're bleeding out on you. So too fast, if it's too fast, is it wide or narrow? Too slow. 3 things I think about if the rate is too slow. Drugs, electrolytes, or ischemia. Obviously, other things can make you get bradycardic. The guy that's shot in the belly with a heart rate of 140 en route to the hospital, now he's 120, he's 90, he's 70, he's 50, he's bleeding out, right? That's the issue with that guy. But you pick that up on your primary exam. These are things you just pick up on the 12 lead itself. So too fast, too slow, or okay-ish. And these are the ones that are scary. These are the ones you got to really understand and recognize. Is that a STEMI? Is it not a STEMI? Is it a left bundle branch block? Is it hyperkalemic? Okay, those are the things that make you uncomfortable in managing these things. I always have a way to figure out your rate. Do not trust the machine. When you print that 12 lead off, look at it. Is it too fast, too slow, or okay by just glance? And then calculate your rate here. I use the box method, 300, 150, 100. If I count 3 more times, then I know I'm going way too slow, right? I'm getting down in the 60s, the 50s, the 40s. You got to know intervals. These are very important. We all learned in basic medic school. Long PR is first degree heart block. That's not super scary with the patient, except in the setting of renal disease. Then you get a first degree heart block. You think they're hyperkalemic. Hyperkalemia kills people. QRS, you got to know if it's wide or narrow. That determines how you manage it. Is it VTAC or is it AFib or A-flutter? It also gives you some idea of hyperkalemia as well. Then the QT interval, very concerning. Long QT causes torsades, syncope, cardiac arrest. You got to know these things cold, guys. All right, so this one, too fast, too slow, or okay. I'll say the rate is okay-ish. The machine says 73. I do the box method, 300, 150, 100, 75, so I'm fine, right? So rate's okay. The next thing I'm gonna do is look at injury patterns, because obviously STEMIs are things we can fix now. So I'm gonna look at leads 1, AVL, and lateral for elevation. So ST elevation, any 2 of these leads is a STEMI. Depression is concerning, but elevation will be a STEMI. The next place I look is leads 2, 3, and AVF. Then I go V1 through V4. These are your septal leads. These are your anterior leads, front, middle of the heart, right? So elevation there is very concerning. If you get depression in V2, 3, or 4, you think about a posterior infarct. That is a STEMI. A lot of times the machine will not pick that up, okay? People try to get fancy with posterior infarcts. If they see this, they want to do a backside of the EKG. For you guys, for me in the ER, I don't need this. If I'm waiting 30 minutes for a cardiologist to see the patient, maybe I do it just for kicks and giggles. But if I got ST depression in any of these 3 leads and 2 of those, and the patient is symptomatic, that is a STEMI. I'm calling a cardiologist, they're going to the cath lab, okay? And the last place I look is lead AVR. So we used to say AVR was only good to see if your leads were on. So if you're up in 1, you should be down in AVR. That's fine. But in reality, if you're up in lead AVR and you're down in any kind of injury pattern. So if I was up in AVR, I got ST elevation here, okay? And now I got depression on my lateral leads. That's very concerning for a left main infarct, something bad going on. Same thing, if I'm up in AVR and now I'm down in my inferior leads, very concerning for a big proximal infarct in the right coronary. And I'm telling you, the machine's not going to pick it up. So years ago, as medics, we all learned how to recognize junctional rhythms. We know, AFib, A-flutter. We know bradycardia, know our heart blocks. We also now got to know 12 leads, okay? When paramedicine started, there was no intervention for heart attacks. We said, yep, you had a heart attack, not good. We're going to hang some lidocaine so you don't go into VTAC or VFib. We'll watch to make sure you don't have a heart block. If you need a pacer, we'll take care of that. And that's what we did. Now we have ways to fix these things, okay? We can make somebody have a big STEMI. They can go home 3 days later and have a normal life. So we've got to be able to catch those. This is just a diagram showing infarct patterns. And again, I showed this a couple of weeks ago. But what's wrong with this picture? Anybody see what's wrong with this picture? Yeah, what kind of blood pressure is that? Is that even possible? No, don't trust the machines. You guys should be able to read your 12 leads and know is it STEMI or not STEMI, okay? So machine's gonna get things wrong. Sir? Yeah, yeah. All right, so a couple of cases. Did y'all see that? That's crazy. That's right. Makes you say roll tide, doesn't it? Yeah. All right. 64-year-old diabetic female dispatched to Wendy's. She complains of some nausea and kind of sweaty after an unknown event that happened at a Wendy's drive-thru. Blood pressure is 180/60, respirations are 14, heart rate is in the 70s, set in 96%, glucose is 115. So what are we going to do for this girl? 64-year-old diabetic, diaphoretic, and nauseous. What's the plan of care for her? Give her a Wendy's burger, a Frosty, those are good. Yes, no, don't give her ketamine. So our protocol talks about, we all talk about chest pain with people having heart attacks. In reality, if you think about it, chest pain is a classic finding in medicine for heart attacks or STEMIs, right? But to be defined as a classic finding, that means 25% of the people have to have that when they have that event. So that tells you about 75% of the people don't have chest pain when they're having a STEMI, right? So diabetics, are they at high risk for having coronary artery disease? Yes or no? Yes, very high risk. Why might they have nausea, vomiting, STEMI, but no chest pain? What's the problem there with the diabetics? Nerve damage. Yeah, they don't feel things as well. They get gastroparesis, they can't feel their feet, they get sores on their feet, right? Same thing, they get nerve damage to the heart and those receptors, so they can have big chest pain, but not know they're having the chest pain, right? So very important to think about. When you think about our protocols to get 12 leads, it's chest pain or suspected ACS. So I would say anybody over the age of 40 that's nauseous, right? They're sweaty, they're weak, they don't feel well, or they have chest pain, okay? Those are the folks you want to get a 12 lead. And the reason we do that is because it makes a difference. If it says STEMI, you know where you're going, right? You go into a cath lab, you're not going to be on the wall somewhere waiting a few minutes, and you can make a difference in somebody's life. You can do a good job. If you don't get that 12 lead, and you're only seeing 30 minutes, you get to the hospital, we spend 40 minutes on the wall, you're an hour and a half into the big STEMI before 12 leads have gotten, right? So 12 leads, very important to these folks. You also want to get a quick history and physical with your ABCs and exam. So we teach our medical students, they do a quick history on somebody, then they do a physical, then they formulate a plan. In real life, we can't do that. We do it all at once. So I'm on scene, I'm talking to the patient, my hand's on the pulse. I can say, is it too fast or too slow? Are they sweaty? Are they not sweaty? Are they breathing fast? Are they working hard to breathe? I get all that information in a matter of a couple minutes. And my buddies get him on the monitor, checking the blood pressure. I'm getting a quick AccuCheck. I'm looking, does it say low? I can fix that. If it says high, I know they're bad diabetic, we got issues. Anything else doesn't matter for us, right? And we're starting IV access, and somebody's grabbing the 12 lead and start hooking them up, okay? Past medical history, things you want to ask people. You know, a lot of things people want to tell you don't matter. So I don't care if they had knee surgery in 1984, if they're on vitamins, okay? Really don't care if they're smoking weed, right? What I'm doing with my past medical history is I'm asking questions to risk stratify, to say, am I concerned, are you really sick or not sick? So I'm going to ask this person, are you a diabetic? They say yes. I say, do you take shots? You take pills? If they take shots, I assume it's insulin. That means they're what? A type 1 diabetic, right? Those folks have a higher risk for bad outcomes, bad heart disease. So my brain's thinking, okay, one box check, she's pretty sick, a diabetic, nauseous, diaphoretic, and she's on insulin. Very concerned. Other questions I may ask, ever had a heart attack or a stroke? If she says yes, now I'm really concerned about her, right? We know she has that underlying disease. This could be worsening, okay? Those are the kind of questions you want to ask to kind of risk stratify, how fast am I going to move with this patient to get my 12 lead and manage their issue, okay? Medicines that I'm going to ask about, we've already talked about the insulin. I say, do you take blood thinners? Okay, because if they're on blood thinners, if they're on Plavix or Xarelto or Eliquis or Coumadin, we know they have underlying heart or stroke issues as well. Even if they don't know it, we now know it because they're on that right medicine. Okay, so we got her blood pressure, we got her vital signs already. So STMs, this is just stuff that matters. Those are the questions you ask. And again, this is all to risk stratify. Do I think they're sick or not sick? Okay. All right. So here's our 12 lead. Too fast, too slow, we're okay. Nobody talks. Everybody. Thank you. Yes, the rate's okay, right? So I'm gonna start looking at injury patterns. I'm looking at leads 1, AVL, and lateral. I should already be sweating right now and using profanity in my head. That makes me uncomfortable, right? My eyes really go straight to here, but there's some days I've been up way too long, so every EKG I look the same way so I don't miss stuff when I'm tired, okay? So depressed, super concerning. That looks good. That makes me uncomfortable. Ooh, that was pretty cool. That's not good. All right, Chief, how do I get that back? You know? Oh, there we go. All right. I got to ask Chief Ward. He's a millennial. He helps me out with all my IT stuff. All right. Then I go 2-3 in AVF, and what do you see there? Elevation. So is this a STEMI or not a STEMI? It's a STEMI, right? Yeah, this makes you uncomfortable. This is what we talk about. People used to, a long time ago, said those are the Pac-Man ghost, right? These are tombstones. I don't care what you call it, as long as you recognize this is a STEMI. This person is high risk for death very soon. This is why we got into the field, right? These are the people we want to take care of. We can make a difference. We can get them to a cath lab or get them licensed, and they can still have a good life down the road. Some things we can't fix. This we can, but we can't fix it unless we catch it, right? So big elevation inferiorly. I go look, finish out my plan, V1 through V4. That makes me uncomfortable. I go look at AVR. AVR looks fine. In my mind, I'm thinking STEMI, all right? I go back, I look for my intervals. PR interval's fine, QRS is reasonable, QT is fine. And before I lay this down, in my mind, one more time, I go through 1 AVL, 2, 3 AVF, V1 through V4, and AVR. So I've looked at this thing twice. I've done the intervals. In my mind, I'm confirmed it. This is a STEMI, right? Cool. So now what do we do for this person? I got a 60-year-old female, diabetic, nausea, having a big freaking STEMI. What are we going to do? Drive fast. Okay. Yes, sir. Yes, you're correct. So I'm a big proponent that medical emergencies, you guys stay on the scene and you manage them. So cardiac arrest, there's no reason to transport until you get your ABCs, you figure out what's going on, you manage that patient. But you can't fix this in the field, right? They need a cardiologist or we need pre-hospital lytics. So do drive fast. But as you're picking the patient up, moving toward the rescue to get them to the hospital, what things are we going to do? Yeah, yeah. Perfect. So IV access, we're working on that. IV access is in. We're checking quick glucose. I'd hang fluids already and have that ready. I may not bolus them in at this point in the game, but my fluids are there in case we've got to give medicines or she goes into cardiac arrest. Sir? Blood pressure is 180 over something, so she was not hypotensive. Cool. We all learned about MONA, and I know I'll harp on this some. What does that stand for? Perfect. Yeah. So morphine, oxygen, nitro, and aspirin. Of those, what's the most important? Aspirin. Yeah. So aspirin jacks up your platelets. So if she's got a big clot in this vessel and she's got EKG changes because everything downstream is now ischemic, if I give her aspirin, the clot's not going to break up. But what's going to happen is the clot won't get bigger in theory. So aspirin's very important. What are the contraindications to aspirin in somebody having a STEMI? So I would say if they have chest pain and they're not having a STEMI, if they have ulcers on blood thinners, I don't give them aspirin. If they're having a STEMI, everything kind of changes, right? All right, game's changed. So I say the only reason you don't give somebody aspirin is they have an anaphylaxis history to it, and that's probably pretty rare. What if the patient said, I took an aspirin 20 minutes ago? What do? Ask what size, and then say, are you sure? So when you guys give a patient that's having a STEMI aspirin, I don't give them another one. When the patient takes an aspirin, I give them another one because sometimes their aspirin was really Tylenol, a Motrin, a Lortab, a gabapentin. You never know what they took, right? So they get an aspirin because if I give them two, I'm not going to kill them. If I don't give them one, we may have a bad outcome. So aspirin, very reasonable. In nitro, how does nitro work? Vasodilate. So it makes this vessel get bigger, more blood supply. I also get some high. So like, yeah, I don't feel good, but I don't care, right? It's like a nice Bud Light. Cool. Oxygen, and then morphine. We already talked about morphine as well. Cool. Questions, comments, statements within reason? Cool. So we risk stratified her earlier. So we talked about she was a diabetic. Are you on those medicines? In my mind, I was thinking about, is she sick or not sick? Once I see that 12 lead that says STEMI, all those questions don't matter anymore because we know she now has a disease. She now has heart disease, right? So now, if I'm going to ask questions, I'm going to risk stratify to determine if the treatment I give her is going to hurt her. So my first question would be, hey, are you allergic to aspirin? Okay, nope, there's your aspirin, okay? And then I'll start asking about medication use. So if it was a guy, are you taking Viagra? Because if she's taking Viagra, can I give her nitro? Probably shouldn't. You can, if the blood pressure is 180/60 and you have IV access and they're hurting, I still pop a nitro in them. If they drop their pressure, you have IV access, you give them fluids, right? If the blood pressure is soft, so the blood pressure is 100/60, I probably would not. I probably get a fluid bolus. If they're still hurting, I give them some morphine. If they're still hurting after that, then I try nitro, but with the caveat that I'm ready to fix that hypotension if it occurs, okay? So initially my questions risk stratified, are you sick or not? I recognized already she is sick. So now my questions go to, can I treat you appropriately? All right. So other questions we got to ask, and we got to ask, can I give you a lytic? So remember, when we have a heart attack, a STEMI, the two things we can do, clots here, we call a cardiologist, they put a wire in this vessel, either through their groin or through their wrist. The wire goes through this clot, they balloon it up, and they put a bridge or a stent. Blood flow gets better. Everybody smiles, the patient goes home happy. All right. If you work somewhere where there's not a cath lab close by, the other option we have is giving them a Clot Buster Tpa, same stuff we use for strokes. TNK is a one-time dose. Retivase is a drug that's used pre-hospital some places that is a clot buster. And instead of having that catheter that goes in, you give this drug, this clot disappears, floats downstream, and they get better. But there's some people you can and cannot give this drug to. So have y'all seen this in the back of the protocol book? Good, somebody said yes. All right, I'm excited. Very good. Yeah, so in theory, you should fill this out on every STEMI patient that you have. In reality, I understand that you don't have time to pull out forms, paperwork, and do this, but still this information has to be gathered, okay? So obviously stuff. Do you think they're having a STEMI clinically? EKG's bad? Does the patient have chest pain, nausea, vomiting? You think they're having a STEMI, yes or no, right? If it's been more than 12 hours, we don't lyse people because we think if this clot's been there for 12, 24 hours, you may get some breakdown of the vessels distally because there's no blood supply, and I give them a thrombolytic, and that dissolves, but then that vessel wall dissolves, and they bleed out, and there are issues with that, okay? So timing of when the symptoms started is very important, and then we got to determine, can we give them medicine? So if someone's having active GI bleeding, it'll be concerning to give them a clot buster, right? If they had a recent hemorrhagic stroke, you can't have more blood in the brain, people die from that. So these are the questions you got to ask them, all right? And this will determine, do you go to the closest hospital or do you go to a cath lab available hospital? Currently, every region has their version of a STEMI system, access, send the 12 lead to the hospital. Do you go to the cath lab or not? The state's working on a statewide system where we have access points where people can stop and get Retivase or actually TNK or TPA and then move on down the road. So in the coming year, this is going to be very important to be able to ask these questions and know, are they a candidate for TPA? Because if they are, you may stop at a hospital that doesn't have a cardiologist, and the ER doc sees them, looks at EKG, takes this information from you and says yes or no to TPA or TNK. And then we're on the phone with TCC again, and they find them a cardiologist, and they go see that cardiologist a few minutes later. Because time is muscle. If you got a STEMI, you want to lyse somebody with this drug within 30 minutes. You really want them in the cath lab within 90 minutes. So those are pretty lofty goals there, right?
Hey, Doc.
Yes, sir.
Had somebody text in and ask, how important is the EMS 12 lead to patient care decisions was the exact question.
It is very important. So in the hospital, we have a rule, door to EKG is 10 minutes. If we don't meet that goal and the patient is having a heart attack, then it's a lofty goal because if we don't meet that goal, we cannot bill Medicaid, Medicare. We get no money. So hospitals don't like that. But more importantly, time is muscle, right? So if I wait 45 minutes to get an EKG, my patient's been out there having a heart attack for 45 minutes, I didn't know it. For the pre-hospital EKG, hospitals are now looking at the pre-hospital record, and they're looking at time from patient contact. So when you say dispatch, I'm on scene, to time to EKG in your chart, to time to EKG sent to the hospital, so we can get the cath lab available. So it's very important to get that early 12-lead EKG, because if you don't get it when you first get there, you may be on scene 20 minutes getting a better history, doing other things, trying to decide what needs to be done, versus you get there, you're doing your primary exam, you're talking to the patient, you get that 12 lead within 4 or 5 minutes, and you see it's a STEMI, now you're up, moving to the hospital. So it's very important to get that 12 lead. Cool. So we talked about the mononeurotic. American Heart says if you're having chest pain, you don't need oxygen, and this you're hypoxic, you're tachypnic, or your sats are less than what, 96%? And I agree with that. However, the rules change when you're having a STEMI. If someone's having a STEMI, they need oxygen. I don't call it supplemental O2. I call it pre-oxygenation before they go into cardiac arrest. So as I'm moving toward the hospital with them, I'm putting a couple of nasal cannula on them. And that way, if they do go into VTAC, VFib, something happens, I can crank that O2 up to high flow. At least now I got 8 to 10 minutes of high flow O2 for them. They're not going to be hypoxic. I can do my CPR, my IV, my defib, whatever needs to be done. So there's no risk to giving someone oxygen if they're having a STEMI. No risk. There's good data that long-term high flow O2 in somebody in the ICU who's had a STEMI or a stroke and they're not hypoxic is bad, but for the 4 or 5 hours you're going to have them that I'm going to have them, there's no risk. Cool. STEMI, no STEMI. Machine says it, but always look at yourself. The rate looks reasonable, not too fast or too slow. 1 AVL lateral. Oh, that's enough. I'm concerned. My brain's still going to look 2, 3 AVF. Super scary, right? V1 through V4, super scary. AVR is fine. Big freaking STEMI, right? 2 things that kill you with the STEMI early on, VFib, all right, dysrhythmia, or complete heart block and heart failure. Cool. So these folks having STEMIs, we talked about they need oxygen. They also need defib pads, all right? Otherwise, what happens is they go into VFib, they have no oxygen on, you're in the back of the truck by yourself. Now you got to pull over, start CPR, get help. All right, if you already got the pads on them, you just put your cigarette out, charge it 200, fire it once, and keep moving. So the previous EKG I showed you, this was the pre-hospital EKG. A lot of times we get them like this. If you have a way to transmit them from your life pack or your Zoll or your Tempest, whatever you're using, it's better. But even a picture gives us enough data. I can look and see this is a big inferior, makes me uncomfortable. So yeah, I'm calling the cardiologist. We're gonna get the cath lab ready. When I call that cardiologist, that means I'm calling a dude, I can't say dude, a physician who's had, at least 6 years of postgraduate training. I'm calling in a couple of assistants. I'm calling in anesthesia. I'm calling in the cath lab techs. I'm probably putting, $30,000 on the hospital right there in staffing, okay? But that's okay, because that's our job. That's what we got to do, is help people. So getting that EKG just very important. That's the big STEMI. Nope. This is that guy's heart cath, or ladies, not guys, sorry. So this is that wires up in their groin, that squirts some dye, and you can see how the vessel kind of goes, and then it stops. It's faint there, a little bit of occlusion there, but completely stops here. They go in, balloon that up, put a stent in, and now you can see we got great perfusion. So have we mucked around for a couple of hours, not got the 12 lead, not done a good job, this part of the heart would have been in bad shape. So now that 64-year-old that works at Wendy's can no longer work there, because now she has heart failure and she gets short of breath taking 20 steps, right? So lifestyle, big changed. And now, because we did a good job, they're going to do fine with this. So that's why 12 leads are important, because we can actually fix those things, okay? This is just a schematic overlaying that 12 lead that we looked at earlier. And you can see we're up in 2-3 in AVF, and that's the right coronary. Some people have a left dominant, so this left vessel wraps around and comes around the right, but most folks is the RCA. All right, this is anybody have dialysis down this part of Alabama in the south? Yeah, right. Yeah, we got a lot of diabetes, hypertension, heart disease, obesity, renal disease. So we see a lot of this. So this was a guy, 50-ish-year-old fella, missed dialysis for the past 2 times. He has shortness of breath, a little bit tacky. He's breathing way too fast. He's hypoxic. Blood pressure is a little bit high, even for Alabama. That makes me uncomfortable. All right, so he's a little diaphoretic, sitting upright, got crackles. What's going on with this guy? Yeah, he's got congestive heart failure. He's got fluid on his lungs, right? So folks who have pulmonary edema, so heart is here, you get a lot of fluid in these lungs, if you have heart issues, congestive heart failure, you have a bad heart, this fluid gets in here and the heart can't just pump it out. If that blood pressure is 220 over 130, all right, that means there's 130 is the pressure the heart has to push against. So a weak heart is not going to push good against that. So this fluid in the lungs does not get better until we fix this blood pressure, right? Cool. Folks on dialysis, they can't pee off fluid, so they get total body overload. So these vessels get real wide, full of fluid, and you get fluid build up here, okay? So there's a mnemonic that I like. It's called LMNOP. I'm not a big mnemonic guy. I like the ABC. I remember that one from EMT school, right? But this is another one I like. It's called LMNOP, and you work your way from the bottom up. So what does P stand for congestive heart failure or pulmonary edema, you think? Perfusion. That's a good thought, but I'm way simpler than that, guys. So position, right? So dude laying in his bed, you show up, he's breathing 30 times a minute, he's gurgly. What are you going to do first? Sit him up, grab his collar, pull him up, somebody get behind him, hold him upright. If there's fluids in the lung and he lays flat, it layers out, people drowned, they don't do good with that. Sit him up. Even if he's 3/4 full, you can still get air to the top portion of the lung. So position, sit him upright, okay? The other part of P is pressure. So what can we do? Put on to help him breathe. CPAP. CPAP is like cheating, right? So CPAP increases the pressure in the lungs, so that makes less blood go to the right side of the heart. So left blood goes in the lungs, so the left side can pump the fluid out better. So CPAP, BiPAP, if you have a ventilator, works great, but sitting them upright and CPAP saves a lot of these people, buys them time so they don't get intubated, okay? Perfect. What's O stand for? Oxygen, duh. And then nitro. Nitro is pretty good. What does nitro do? Two things, how it helps people with decreases preload, right. It dilates these vessels, so less blood returns to the heart, so that weak heart can pump the fluid out of the lungs, they breathe better. What else does it do to the blood pressure? Drops the blood pressure, so now the left side of the heart doesn't have to pump hard to get the fluid out. So nitro is great. So if I had this guy here, I would show up, I'm talking to him, hands on his pulse, somebody's gonna get a 12 lead, get IV access, I'm gonna sit him upright, somebody's gonna get behind him, hold him up. BiPAP's coming out, I'm gonna pop a nitro under his tongue, put the BiPAP on him. Does he need IV access before he gets nitro, this guy? No, his blood pressure is sky high. I'm not gonna bottle him out. So I'm gonna pop one, put the mask on him. If it was me and not you, I'd probably pop two and then put the mask on him. But you pop one, put the mask on, and then recheck a blood pressure in 5 minutes, take the mask off, pop another one, okay? What's the M stand for? Morphine. And morphine we talked about earlier, dilates vessels, lowers his blood pressure, and that's why it works, okay? So morphine is good. What is L? It's a drug you use all the time. That's a joke. You don't use it all the time. Lasix. Yeah, right. It's Lasix. And, you know, Lasix on somebody who has kidney problems is not going to work because Lasix makes you pee. If he's on dialysis, he does not pee already, right? So, but Lasix you can use. We use in the hospital. Anybody admitted to the hospital with a diagnosis of heart failure or pulmonary edema, if we don't give them one diuretic, we can't bill Medicaid, Medicare, supposedly. So we like Lasix. But from a pre-hospital standpoint, it's not very useful. And in the ER, I don't give a lot of Lasix to these folks either. Most of the time, it's sitting them upright, CPAP, nitro, high flow O2, maybe a little bit of dirty morphine, all right, and they get better with that. All right, another, yes,
hey,
sir.
Doc, hey, we got a question, kind of got to back up a little bit, but somebody wrote in and said, I got fooled by what I was told was early repolarization with syncope, shortness of breath, and severe chest pain. Is it important that I be able to differentiate in the field or just assume it's ACS?
It is no, it's not important. So early repoll or benign early repoll is usually seen in younger folks, folks with young, healthier folks. And it looks like ST elevation. Usually it's pretty diffuse. It's everywhere, lateral, inferior. But the thing is, if you see that ST change and now they're having chest pain, trouble breathing, it's not your job to determine is it a STEMI or not STEMI. It looks like a STEMI to you, so you call it one. So there are times in the ER I get these folks, the young, healthy folks in the early 20s, they got Repoll in the EKG. It looks like a big STEMI. They have no symptoms. I'm not calling anybody. It looks like Repoll. If that 28-year-old comes in and says, I can't breathe, my chest hurts, he's sweaty, I'm calling a cardiologist, and then they can make that decision. So the short answer is it does not matter. If it looks abnormal, you think it's a STEMI, put it in the system. We rather have a false positive than somebody missed a STEMI. Does that make sense? False positive. Yes, no. All right. I think my caffeine titer is getting low. Sweet. All right, this one, too fast, too slow, or okay. I think the rate's okay. If you want to be technical about it, we can count it out. So 300, 150, 100, 75-ish. So yeah, it's fine, right? So I'm gonna look injury patterns. I'm looking 1, AVL and lateral, not scary. 2, 3 and AVF, look reasonable. V1 through V4, not super scary. And then AVR doesn't look bad, okay? What do I do next? Look for intervals, right? So intervals, P interval looks fine. My QRS is narrow. That's my Q wave. That's my T wave. Normal, abnormal? Anybody care? Long. Yeah, so long. So we have a long QT, right? So in your mind, you think, okay, that's concerning, right? It's not a STEMI, but it's a freaking long QT. Before I get done, I'll look one more time at injury patterns. That I put the EKG down at that point. But I remember this guy's got a long QT. What can a long QT do to people? Yeah, you go into VFib, VTAC, torsades. So if you show up on scene, you got somebody that passed out, and you do a 12 lead, and you look, oh, it looks good. No STEMI, they're not too fast, they're not too slow, but that QT is long. They may have passed out because they had to run torsades, okay? So now your job will be to motivate them to go to the hospital to get further testing to make sure it doesn't happen again, right? Because we call torsades where you pass out and you wake up, it's called syncope. What do you call torsades when you have it and you pass out but you don't wake up?
Dead.
Yeah, very good. Good. I like that. Good. Good. Sweet. So long QT, concerning. All right. When I think about QT intervals, if it's more than half the R to R, if it's more than half, oh man, I'm killing it. If it's more than half from there to there, it's very concerning. So if you look at this to there, do it for the folks online. So there to there, that's more than half, right? That's end of the T wave there. So very concerning, long QT, a lot of bad things can happen. There are a lot of drugs that cause this. All right, a lot of drugs out there. So Tagamet, antibiotics, HIV drugs, anti-fungal drugs, diltiazem, Haldol. Anybody ever given Haldol before? Haldol prolongs the QT. Diphenhydramine. What is that drug? Benadryl, yeah. So a lot of common drugs prolong that QT. What's a drug you give all the time in the field for nausea that prolongs the QT? Zofran. Yeah, so if this guy gets a little dose of Zofran, he may have an issue with that, right? So this is the monitor of a patient I had in the ER one night. And I was in the trauma bay. They came and said, hey, dude in 14's in cardiac arrest. And I'm like, dude in 14 just got a turkey sandwich. What are you talking about, right? And sure enough, he was in cardiac arrest. But what is this rhythm here? Torsades. If you don't want to be fancy, say it's VTAC or VFib. I'm fine. It's the same game, right? So how do you manage this? What will be the first drug you give this guy? Mag. How much mag you give?
1 day.
Oh my gosh, I like this. Great. I feel smart now. You sound very confident. Yeah, dude's dying right in front of you, man. Yeah. Yeah.
I want to say it's like 2 grams.
It's 2 grams.
Yeah.
Yeah. 2 grams of mag. How fast do you give it?
Fast.
Very good. Is guy alive or dead? He's dead. So give it as fast as you can, right? Yeah, magnesium. 2 grams of mag. He gets 2 grams of mag. He gets high quality CPR. We start thinking about an airway, and he gets pads on. He gets defibrillated really quick. Okay. So needs magnesium. Perfect. So it's torsades. So long QT, you get an ROT phenomena. Sometimes the body will get out of it, and you go back into another rhythm again, like on this one. This was an old guy that fell. He kept passing out at the nursing home. He kept coming in, getting sewn up. And we finally caught this on the monitor. And we're like, oh, he's not just tripping. Okay, we were tripping, right? He was having torsades. So magnesium, perfect. So this was a patient, frequent flyer. He was had underlying mental disease, was on a lot of antipsychotic medications. All psychotic medications prolong the QT. He wanted a turkey sandwich. Somebody gave him some Zofran, and it kind of pushed him over the edge. So I'm not saying you get a 12 lead on anybody you give Zofran to, but think about your patients. If you have a schizophrenic on numerous antipsychotics who is now nauseous, who's also an alcoholic and homeless and probably dehydrated, right? Before you give them Zofran, do a quick 12 lead. Look at that QT interval to make sure you're fine. Otherwise, you'll be given magnesium and defibrillation and sweet. About out of time. I'm not going to show the videos. The other thing I want to mention is I know with staffing shortages throughout the state, there's a lot of issues getting AMTs and paramedics. The EMT, we used to call the basic EMT, is the backbone of EMS, guys. I mean, that's where you learn your first things on patient assessment, hands-on training. There are things that I learned 30 years ago in my EMT course that I still use today as far as airway management, jaw thrust. Even when I go to intubate somebody using all these fancy drugs, I got an OPA in my pocket. If I can't ventilate them, that comes out and it goes in, okay? So the point of this is the scope of practice that our EMTs have is growing and growing. So they could do CPR, they can deliver kids. We can do blind insertion devices. So EMTs can do eye gels, Kings, things like that now. The responsibility is getting higher and higher. So you guys as the medics need to make sure that your EMTs are trained and get experience doing this stuff, okay? Because these are the guys that we fall back on. So we got to take care of each other and make sure these guys are trained and up to date. Questions, comments, statements within reason. Cool. We'll take a few minute break and then Dr. Rose talk about chest trauma and maybe that'd be more exciting. Yes, sir.
So I don't have much experience in that medical field, so I'm just EMT.
Yes.
What I learned is like when we have a cardiac issue, right? There could be a radiating pain to the back or to the arms.
Yes.
So that's we never discussed. So I was just wondering that sometimes the chest pain will be there, sometimes they will not have a chest pain.
Correct.
They could have a radiating pain.
Right. So you can have a cardiac event. You can be having a heart attack, a STEMI or an in-STEMI as we call it, and you can have chest pain, or you could just have shortness of breath and nausea, or you can have pain to your shoulder or pain to your jaw. It's just there's no one answer to that. So that's why you got to look at the patient as a whole. If they're an 80-year-old person having jaw pain, does an 80-year-old have heart disease? Yes, I would say yes. Everybody that makes it to 80 probably has heart problems. I would be concerned they're having heart problems. So those are the folks you want to work up and make sure they get that 12-lead EKG, and you get ALS there and get them to the hospital. Does that kind of answer your question in a fast, hypocaffeinated state? All right, let's take 5 minutes and we'll come back with Dr. Rose. Thank y'all.
Hey everybody, welcome back. We've got Dr. Amy Rose from UAB with us here this afternoon, or this morning, I guess still, to lecture about chest trauma. So thanks for being here, Dr. Rose. Take it away.
Sure. So I don't know, there's a few faces that I've seen before, but my name's Amy Rose. Just a little bit about me. So obviously I'm not from here. I'm from the other Birmingham, a couple thousand miles away. Came over, did the military for a bit, was a medic there, got out, ran fire rescue in Virginia, and then decided to go med school. So that's kind of where I'm at. So anyway, right now I'm one of the residents over at UAB in the emergency department. So if ever you transport someone and you see me, please say hi. All right, so we're talking about chest trauma. So the big goals of this is to be like, that's not good. This is what I'm going to do. So you don't need to like know the huge nitty gritty kind of all the statistics and outcomes and all that. It's just recognizing being like, that's real bad. That's kind of bad. That person's dead. Let's get some things going. So we always talk in trauma about the cardiac box, and usually, you know, it's down from the clavicles, in between the nipples, up from the costophrenic angle. Anything kind of in this box is super bad, but it's actually kind of shifted off to the side. And in my head, I don't care where you're getting shot or stabbed or hit. If it's anything above here and the patient looks sick, like the patient is sick. So most of the the information that I got is from the Society of Academic Emergency Medicine. That's kind of one of our agencies in emergency medicine, as well as the 10th edition of the ATLS book, for those who have done it. And I'm just letting you know now that there's a couple of gnarly pictures in here, so be warned. So this is, who's been to UAB, like in the trauma bay? Has anyone dropped anybody off there? So a couple of people have. So this is kind of like our usual setup, and the reason that I bring it up is because we always have this same way that we do things. We have our primary, we have our secondary, we tend not to deviate from it. It works well for us. If we do it the same time every time, then it minimizes the chance of us missing anything. So, you know, you guys will come, drop someone off, and then you never really get to see kind of what happens after. But in my head, if we all kind of get on the same page, then it's kind of like a Swiss cheese model. Like if you guys don't miss it, you know, we don't miss it, it kind of helps minimize us missing anything that could potentially be catastrophic. So usually the way that the team works is we have the patient, there's usually a lead resident, and then you've got your attending, airway anesthesia, all that kind of good stuff. And all of this is prepped based on the information that we get from you guys. So the information, the vitals, kind of, you know, what you guys can tell us, the more accurate, you know, the better it is for getting us set up. So obviously going through your ABCs, airway, right? Airway is always the biggest one. It's very rare that you get to see like real bad trauma to the face, but it happens, you know, especially in these patients that are a lot of the time suicidal, you know, they've took a shotgun to the head. You know, everybody I was just minding my own business and, you know, they got shot. If you bring a patient in and they have a tube like that, I'll be the most impressed. I will personally buy you a trophy and shake your hand, because that, can you imagine like pulling up to scene and seeing that? What are you gonna do? Well, I hope he's got some set going on. This is just a quick reminder that airway isn't just trauma to the oropharynx or, you know, oxygen saturations. It's also about mentation. That also plays into effect for airway. And the question is that I always want to ask yourself is, are they making noises in the airway? Like, is there an obstruction? And then the second thing is, if that patient vomited right now, would they be able to cough it up or spit it out? Because if the answer is no, if they're like lying flat on their back and they're not responding, you'll stun or rub in. If you know that they vomit, they're going to aspirate that. That's an airway issue. And then obviously looking for any other signs aside from trauma. So this picture right here is showing us tracheal deviation, and you know, that's a big red flag sign for something bad, and we'll talk more about it as we get into some of these cases and go over some of these kind of scenarios. So obviously breathing, you want to check lungs both sides, see how they're sitting. This is specifically for trauma, you know, either blunt or penetrating. You want to make sure that you get good lung sounds. And sometimes, honestly, it's really hard. They've got underlying disease, it's super loud on scene. You know, it may sound as if it's like diminished, but just do the best that you can. Checking pulses. We always check femorals, but to me, if you've got like a bounding DP pulse in the feet, or if you've got bounding radials, that's a good sign for me, especially if you're maintaining well at the same time. And then obviously, if you've got like a crazy bleed going on, you want to probably stop that before the vitals start to get wacky. So just, you know, basic first aid stuff, putting pressure on, blocking off the artery with the tourniquet, whatever you got to do. And then another thing is like your GCS, so that's like your mental, like your neurology. And when somebody comes in, we usually ask them two things before they come in. One, tell me your name. I'll be like, what's your name? Austin. So that tells me, one, that your airway is open, two, that you understand what I'm saying, and three, that you're able to communicate back. That tells me a lot of information just with you saying that one word. And then I'll say, wiggle your toes for me. And they wiggle their toes. And that tells me that one, they have some form of motor function distally, and that, again, they're able to follow commands. And then I'll just take a quick look at their eyes, because in these trauma patients, especially if you've got some kind of blunt trauma, I don't know what other trauma you got going on. Like, you know, we're talking specifically like this area, but you know, with these car accidents, you got hit in the chest, chances are you've got hit in the head as well. So there's chances for other things. All right, so say You go, it's a nice morning, super nice weather. You're out at the station, you're like, this is going to be a really nice chill day. And then you get a call and you're like, oh my God, someone got stabbed. Like, what? Let's go and find out what's going on. And you show up, and this is what you see. And he's otherwise, like, he's in a lot of pain, but, you know, he's not doing too bad. What are you guys going to do? How are you going to stabilize him? What does that mean? Yeah. So, quick plug here is the heart itself is not like, it's not centered nice and straight, and you know, if you get stabbed in the middle, it's going to go through the septum. It's kind of twisted. So the first thing you're going to do is hit that right ventricle. So a lot of the times these patients have right ventricular damage. So a lot of the times they're fluid dependent, or at least, you know, like you want to get some kind of fluid access, just because if they tank, they're going to tank quick and they're going to need that volume, both because they're losing blood and because they're starting to mess their right ventricular function up. So the first thing I'm going to say is get some good access. Like the bigger the better, both sides is better than one side, which is better than none. And then obviously putting them on the monitor, you want to get a set of vitals. You want to see, you know, like how, obviously this is bad. We all know this is bad, but how bad are we? Like, are we in the beginning parts of this? Like, are we just a little bit tachycardic? Or are we like tachycardic and hypotensive? Like this is, you know, this is bad times. Don't touch the knife. I showed my husband this last night and I was like, he's not medical at all. He was an engineer in the army. I was like, what are you going to do? He was like, take it out. I was like, no. And he was like, well, I guess I'll put it back in then. I was like, no, don't do that either. Just leave it where it is. Don't put any straps around it. Just when you say stabilize it, I mean, like, stay away from it. Like, don't touch it. Don't get any wires over it. You don't want to wiggle it around. So let's say you've done all your things, you get into the hospital, drop them off, the surgeon's going to do what they do. Everybody is like, wow, you know, saved a life. You get back and you're like, man, another call, like somebody else got stabbed, like the same people, different people, what's going on? So this time you show up and it's a little bit different. So now you've got this. How are you going to approach this? Are you going to approach it the same? Are you going to approach it different? What are you going to do? How are you going to approach it different?
Occlusive dressing.
Yeah.
Based on that sounds.
Yep. All of the above. So listen, do we have breath sounds both sides? Because sometimes you'll see that and it hasn't actually like penetrated the actual thoracic cavity, and they actually have great lung sounds. And honestly, when they come to UAB and it's just a little, you know, skin nick and they haven't actually violated the pleura, give them a tetanus, sew it up and send them on their way. Like, you know, have a great life. Stay away from that craziness that happened. But what about if you listen and you don't hear a single thing on one side? That's a little bit more concerning, right? Especially in the setting of them having chest pain, trouble breathing, low oxygen, whatever. This is your vitals. What do you think now? Yep, same patient, no lung sounds, say on this right side.
Yeah, he's got a pneumo problem.
Yeah, that's exactly right. He's got oxygen problems, right? There's something going on that's messing up with his lungs. So this is a pneumo. It's just a simple pneumo. So the problem is that you've got air in the cavity. It's going in one way, not coming out the other, and you're starting to get lung collapse. Now it's affecting, you know, your oxygen saturation. And if you go back, you can see that they're a little bit tachycardic. It's reassuring that their blood pressure is up though for now, right? So it's like, for now, it's up, it's fine. But obviously we want to do something about that. Most of the times I will say for these patients, put them on some oxygen, even if they're just like on the lower end of normal, if they're 93, 94, just put them on some oxygen. Because a lot of times, even if we've got someone that has a non-traumatic pneumothorax, like if they've got emphysema or blebs or whatever that's popped, we usually put them on like 1 or 2 liters nasal cannula just because it helps to wash out that space. Another thing that you can do as well is a lot of the times people have the valves that you can place over it. The big thing about this is making sure that you actually put the valve over the wound, because it can get hectic. And if you see this and you've got your patient and he's decompensating, or, you know, you've got the patients where obviously there's something wrong, but they're also a little bit dramatic and they're flailing like, oh my gosh, I'm dying, I'm dying. You're like, Well, not yet, maybe later, but not right now. So you're going to want to put that valve on, because what that's going to do is it's going to allow the air to come out but not go in. And we'll talk about, you know, kind of what we're preventing in a little bit later. But as you said earlier, I don't really care like what you put over it, as long as it stops air going in to the chest itself. And that's where like occlusive, like more occlusive dressings come in. It's like your petroleum, your Vaseline gauze. You want to get your wound, put it on, put a little 4x4 on, tape it down 3 sides. The ATLS guide is just like tape it down 3 sides. When I was in the military, they always taught us put the opening down. And the opening down because if you've got like a hemothorax portion of it and that fluid comes out the lung or out the pleura, if your opening is up, it's just going to sit and pool in the bottom if you've taped it down well enough. Whereas if you put the opening at the bottom, it can kind of drain on the sides. So that's my thought process on it, and it just stuck with me. Oh, wow, what a day, another one. All right, so same patient, we're going to listen. We don't have lung sounds. This is your vitals now. What are we thinking? Yeah, so this is real bad, right? Like, okay, now this patient, you know, maybe they're not responsive, maybe they are responsive, maybe they're just that patient that has the flare of drama, but you've also got objective data to be like, something bad is happening, like, holy smokes, we got to do something about it. And this is where we start to talk about tensions. So pneumothorax in itself is bad, easily treatable, put a chest tube in, you know, it resolves on its own. Tension, very, very bad, especially when you've got low blood pressure. You're like impending death any minute at that point. So what you gonna want to do is needle decompress. Now the bad thing about the tension is that you're not only collapsing the lung, but now you're starting to collapse the heart. And when you start to collapse the heart doesn't like it. Neither does the rest of the body, because now you're not pumping blood to the rest of the body. So grab whatever big needle you can, whatever you find in your bag. You know, they say 14 gauge, 2nd or 5th intercostal space, you know. Find the biggest one you got and put it in. Like that's, like if you've got someone that's tension, you know, they'll say the mid-clavicular line, you know, if you kind of feel your sternal notch, you kind of feel down, you'll feel a divot, and then you kind of go across, you know, that's great. Sometimes they'll say, you know, I think the latest guidelines is shifting more towards the mid-axillary line, anterior axillary line at the 5th intercostal. Ferg, I don't know what your thought process on this, but a lot of the times when we go to the scene for these patients, you know, they're already lying down on a gurney. You're getting them hooked up to the monitors. They're not like, you know, a pharma unit or a firefighter unit. They're like a McDonald's unit, right? So all that tissue that you had on your anterior chest when you lie down, now it's on the side, right? So good luck trying to palpate some landmarks on the side over here. And especially even if you get the needle in with the shifting tissue, it's, you know, the needle's going to move about. And I'm just like, if you feel it, go for it, especially if you've got vitals like that. Just pop it in, be done with it.
So the safety protocol is listed on the webpage now. Can I hear me, sir? Is category B. However, the last SMEC we had last June, it was actually discussed that it was category A. Somehow it got changed on the webpage. So we got to talk to the state about changing that back. But tension pneumothorax is decompression is an emergent procedure. Somebody's going to die if you don't fix that. Upright talking to you, they got no lung sounds. That's not a tension. So tension pneumothorax is a pneumothorax with signs of tension, which is either hypotension and ultramental status, or it's pneumothorax and cardiac arrest. So now I agree with Dr. Rhodes. I go interior. So many folks in Alabama are big. I can push back tissue of the chest down and get anteriorly, or sometimes going lateral is tough. The other problem that I've seen is lateral approach catheters put in, and we get a chest x-ray, and that catheter is actually under the diaphragm, so it's real easy to go low here. I know the tactical paramedic programs, the critical care programs are all talking going lateral, and you can, but just be wise with that and make sure you're going high enough and actually get in the chest cavity. I still go anterior.
And we still do anterior like in the trauma bay as well, because it's easier to access. You know, you've got nurses on both sides kind of doing things and, you know, shifting everybody. Just put it in. Like if there's any like question about if there's tension, if you see any kind of tracheal deviation, they're struggling, they're O2, you know, if they're unresponsive, they're not bagging well, they go into a rest, just decompress. And you can use the needle or the angiocath. I know that sometimes, you know, when you pull the needle back, the angiocath itself isn't stiff enough, so it can kink off real easy, or, you know, you could resolve that initial tension, and then all of a sudden your vitals will start to deviate again. Decompress it again, like if you have to, like just do what you got to do in order to release that tension and kind of letting that lung, the heart expand and contract the way it's supposed to. All right, so a little bit different. You get back now. Now we've got an unrestrained driver in a car accident. You listen to the lungs. You don't hear anything. This is your vitals. What do you think? Yeah, exactly. It's like a tension again. So like you don't need any kind of penetrating trauma. You can get tensions from blunt trauma as well. So how is that possible? Rib fractures. They are. Like you don't think that bones are that bad, but one of the common procedures that we do up at UAB is, you know, I'll put chest tubes in the trauma bay, and you'll go in and, you know, you'll feel your landmarks. If you've got a broken rib, those suckers can be real sharp and they can cut your gloves and cut your hand. So even if you've got like some bruising or redness over the chest, if if they've got tenderness and there's signs of tension, decompress it, because it's essentially like if they've got really badly displaced ribs, a piece of glass stabbing their pleura, like constantly every time they move. So you can still get tensions. I don't know if this is going to work. Let's see if this video will work. Is it going to work? No, it's not going to work. Well, either way, when you see a flail chest, you'll know what it'll look like. There's like no mistaking it. You can see like a bit of a broken rib come up, but seeing a flail chest, you'll just be like, that is AB normal, man. And I'll be like, yes, you are accurate. And this was another video of a really bad one. And it's hilarious on this one because this guy is flailing around in the gurney, has this massive flail chest. And the physician, whoever they are, he or she, is like prepping the area to do a thoracotomy. Don't do that in someone flailing around. Put them down first, if you're going to do that.
Well, actually, sit down.
Yeah.
Not all the way down.
Not all the way down. Close down. All right, so we get another call, this time restrained driver. We listen. This is our vitals. The only difference here is that you've got long sounds both sides at this point. What do you think now? You see this? Yeah. So they've got distension of their vein. What could cause that? It's tamponade. Yeah. So the big issue here is that you've got your aorta, which, you know, comes up, it wraps around. It's kind of tethered at this point here. So when you have like a high velocity and you slam your brakes on, it can tear, and that can cause an acute dissection or an acute rupture if it's bad enough. But the problem is that blood that's in the arterial wall can track all the way down to the pericardium. So that nice space that kind of just holds the heart in place, it kind of anchors it like a sling. Now it's filling with blood, and now it's doing it quick. So you'll have patients, especially these heart failure patients, these dialysis patients, and they'll have effusions all the time. Like we'll look on, you know, we'll get an ultrasound, they'll have an effusion, but they're not in tamponade. So why is this person in tamponade? It's all a matter of like how quick it accumulates, right? So if you are slowly adding like 2 cc's, 3 cc's at a time, that gives you time to kind of adjust. You know, the pericardial sac can kind of loosen up. If you all of a sudden throw 100 cc's in that bag without giving it time to kind of loosen up, there's only one way it's going to go, and that's inwards. And then you're going to start to get tamponade again. So this is essentially like tension, the tension pneumo. You're compressing the heart, and you're causing dysfunction. It's not going to be able to pump blood out. But instead of on one side being pushed against it, you've got it on both sides. And everything that's supposed to go into this little atrium on the right is going to start backing up, and it's going to start backing down into your IVC. You won't see the IVC because you know the belly's there, but this you'll see. Like, it'll be pretty obvious. I don't think that there's anything that you guys are going to be able to do in the field about this other than just get them, recognize it, know there's something bad going on, and just kind of like speed it up. Another example of JBD here. If you have low blood pressure, if you don't hear good heart sounds, we call that VEX Triad. Those three, you know, tamponade should be on your differential, because you're essentially just listening to heart sounds underwater. You know, it's not gonna sound good. You're gonna be like, what's going on? All right, another one, another call. You're like, wow, what's going on? Crazy day. All right, so these are our vitals. Not too bad. Not too bad. I've got real bad chest pain. I've got such bad chest pain. You get an EKG, this is your EKG. You're like, okay, well, nothing too crazy is jumping out. They're like, oh, but I'm dying, it's getting worse. It's getting so bad, the pain is crushing its chest, the diaphoretic. I'm like, get another one. If you have someone and the story is that concerning and they have some kind of blunt trauma to the chest, like, I'd advocate for just getting a quick EKG. If you don't see anything, fair enough. If they're still complaining of like, I'm telling you this pain is getting worse, 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 and you're like on, you know, 20, 30-minute transport until you get to whatever ED, just check another one. And if you go back, you can actually see it here. It's really, really subtle. And if you missed it, I wouldn't blame you. But you've got like a tiny, like 0.5 to 1 millimeter elevation here, without any depressions or anything anywhere, so it's very, very easy to miss. Obviously, this is a little bit more obvious. So, as Ferg was saying, you know, you can check your rate, check your areas, and you can see that this is very local to the inferior lead. So it looks like we've got an inferior issue going on with the heart. So blunt trauma, always your ABCs, getting your IV access. Take into consideration cardiac risk factors in these folks, because they can have like physical damage to the heart, which can cause like, you know, heart issues, sternal fractures, kind of, you know, rib fractures, whatever. But also just kind of the stress of the situation. If they're like really sick at baseline and they have really bad CAD and they're really anxious about the situation and they're like, you know, tacking away in the 130s, 140s, and you know, they can have like ischemic demand. And if you see a STEMI on a trauma patient, would you give them aspirin? You'd be really cautious about it, right? Because the chances, if they have like a real bad injury to the chest, they could have a real bad injury to the belly, real bad injury to the brain, especially when they're not acting right. So just always be cautious with whether or not you're going to give it. It really depends on kind of what they actually look like, how bad the trauma was, is there signs of obvious trauma elsewhere. All right, another call. All right, you see this on your exam. Otherwise doing okay, complaining of real bad excruciating chest pain. Vitals all seem to be okay. They have lung sounds both sides. The oxygen level is okay. What do you think of that? Kind of weird looking, right? It's like not really JVD because it's not like up the vessel, but it's lumpy, it's weird. You feel it and it's like snap, crackly and poppy. It feels like kind of bubble wrap. What was that?
Subcutaneous emphysema.
Yeah, subcutaneous emphysema. So something in these trauma patients is you have to think about esophageal injuries, because while you've got your lungs in this area, you've got your heart in this area, your aorta, your IVC, all of these can be injured. You've also got your esophagus running down, and that can tear just as easy. Especially when like the anchors go through the diaphragm, it's kind of a weaker point. So if you have someone and they're complaining of real bad epigastric pain, lower sternum pain, and they have something like this, be suspicious for an esophageal injury. So in that setting, you know, again, there's really not much in terms of management for these folks in the field. You know, when they get to us, we'll do swallow studies. We can, you know, put a scope down. I would just be kind of careful if you're planning on giving them anything oral. You know, try and stick to IV if you can. Stay away. Kind of that. It's really just kind of managing pain because they tend to have the worst pain with okayish vitals. Fentanyl helps. So just to kind of like wrap everything up, you always want to make sure that you do your ABCs. Consider mentation as part of your airway. Asking them just quick basic questions, it can tell you a lot if they just tell you your name. Making sure that you get good IV access, get a good set of vitals. Look for signs of hemodynamic compromise, even if you're not able to pick anything up on the monitor. Sometimes you'll get these really sick patients and it's not picking up an O2 set, or it's cycling the blood pressure like 3 times. Feel for distal pulses, it can tell you a lot. If you feel like real good DP pulses, real good radial, they're mentating fine. I don't care what the numbers say, there's some level of perfusion going on. So know when to decompress, look for that tracheal deviation, look for signs of a pneumo with your blood pressure being low, or if they're unresponsive, if they are complaining of chest pain, they're hypoxic, you've got them on oxygen, then they go unresponsive, kind of, these should be flags to be like, should I be decompressing right now? Do I, you know, especially if I've got absent lung sounds on one side. Look for signs of tamponade, like look for that JVD, just take a glance at the neck. They're like struggling and again, you know, having real bad chest pain, kind of blood pressure issues. Look for these other telltale signs that can tell you there's something real bad going on. Know that with blood trauma and penetrating trauma, they can cause the same pathology. So they can have, you know, like 2 different causes, but you can still get tensions, you know, still get tamponades with both of them. And then just consider EKGs, especially in your blood traumas, because these folks, you know, these older folks that get into car accidents, if they've got like bad sternal trauma, it can cause like, you know, cardiac muscle damage. So just something to consider. The most important thing though that I want you guys to take away from this, more important than ABCs, more important than anything. Don't touch the freaking phone. Okay, let's leave it. Leave it alone. That's what I've got. Does anybody have any questions?
Hey, Dr. Rose, we had a question come in on pericardial tamponade, traumatic pericardial tamponade. So obviously we can't really do any direct intervention in the field. So fluid bolus or no fluid bolus?
That's a great question. So it depends what they're looking like. If you've got someone that's fairly young and healthy that can manage that fluid, I'd say if they're hypotensive, you can give them a small bolus, but just be very cautious with it, because essentially everything that you're putting back is going to go, it's still going to go through the lungs, still, you know, go the appropriate route. But then when you find that disruption of where the blood is going in, that's when you're going to start to have issues. If you've got somebody that has like bad issues at baseline, heart failure, dialysis, anything that could potentially cause them to third space, liver folks, and they also have a traumatic pericardial effusion, I'd probably say just kind of hold on that. What is your thoughts on that, Ferg?
Yeah, the odds of having somebody that has tamponade is an isolated injury from blood trauma is rare, right? So if you get tamponade from blood trauma, you probably got something going on with your belly, somebody else is bleeding out somewhere. So the fluid of choice will be blood. So not a lot of folks, not a lot of ground to carry that. But if a hypertensive attack you got to give a little fluid, you got to try something. What drug could we give if we thought they were in hemorrhagic shock period?
TXA.
TXA. So TXA is reasonable if they have a hemorrhagic shock. But tamponide's tough. Tough to manage, tough to diagnose in the field. And most of the time with blood trauma, you can be thinking there's other injuries as well that you'd be concerned about. It's more common to get tamponade at penetrating. So the GSW, the knife under the chest, you see tamponade. But again, the treatment for that is quick access to the hospital, you can decompress that. Now, ultrasounds are coming to pre-hospital, to EMS, and that's how you would diagnose that quickly in the field. You put an ultrasound on the heart real quick, and you can see that fluid. So I know there's some paramedic programs buying those things. They're cheap now. It used to be 20 grand to get one. You can get a butterfly ultrasound for $2,000 now. It gives you a lot of data, easy to use. So.
What about similar mechanism as the traumatic pericardial tamponade in a medical setting, in the pericarditis setting? Do you think that's more common than the traumatic tamponade?
They're both really not that common, to be honest with you. I've seen more in the trauma causes of tamponade. Again, the majority of that is from penetrating wounds. I've seen a couple for blunt. I've seen a couple from sick people with pericarditis. The classical, most common thing would be somebody who just recently had heart surgery, had a cabbage, vessel bypass, or a valve replaced, and now they're like, I can't breathe, I'm weak, I'm tired, my chest hurts. You get there, they're ashen in color, they're hypertensive, they look like dirt. That's the red flag to me that, oh, they probably got a big pericardial effusion that's going into tamponade, because you know somebody just cut on that pericardial sac. But the other ones are fairly rare, in my experience.
We just had one this last week, yeah.
I'm sorry. For us though, as towards medics and EMTs in the field, what would be the classic way that we would diagnose them? Vital signs, right? Having an initial baseline vital sign and then checking it later at some point later on.
Right, mechanism of injury, chest trauma, or that cabbage history, or definitely penetrating trauma of the chest. You can start thinking if they decompensate. Two things to think about real quick is you think about intentional thorax or pericardial tamponade. So, we know those.
With the tamponade, though, initially the blood pressure, systolic diastolic come together on the tamponade.
They do, but in my experience, that's really hard. They're also hypotensive, and that's a very minimal change. So I think mechanism of injury, history, and then looking like sick is the big thing.
And that, so classically, like clinically, when you're trying to diagnose a tamponade, that's why they tell us to look for that Beck's Triad. So the one where we're looking for the JVD, we have the low blood pressure, we can't hear heart sounds hardly at all. They have good lung sounds, but for some reason, that S1, S2 is just not picking up.
I guess the other question, since I know I'm low now, everything we've ever been taught is treat the patient, not monitor. So when you don't see any of that stuff, don't dismiss any of that. If the patient looks like
that. And it's all about like the first thing that even like when, I have one of my attendants, like if I'm working with Ferg and I'm a med student or, a new resident, an intern, is I'd be like, first of all, I want you to identify sick or not sick. Like that's a big question. Are they sick? Are they not sick? Because if they're sick, you don't need a number to tell you that. You're getting like they are diaphoretic, like you said, they could be ashy in color, yellow in color, their color is just off, they can be completely white, they're cold to touch, they're burning up, like you just know that there's something wrong. And then everything else is kind of like additional data points. So like at UAB, we're kind of taught not to really rely on the monitors as much, especially when we've got the trauma patients come in. Because a lot of the times, if their blood pressure is so low that it's not picking up, you've got to look for just classic physical, exam findings. That's really going to tell you how sick this patient is. So if I feel their radial, and I know, I don't know what the rate is, but I know it's like do. They're diaphoretic. I touch their legs, they're cool. I can really hardly palpate any DPs. First of all, I'm thinking, what do I have for access? And the second thing is, where's my blood? Where's my quick pack? Where's, hang it, we got to get it going now. And then afterwards, oh, look, now we have an oxygen level and now we have a blood pressure reading. The problem is that it just wasn't there to pick up before. Like it was just too low for the monitors to pick up, so.
And when we say sick or not sick, our definition of sick is different than the general population, right? So you can have somebody sit there with a open fever calling you mama names, but they're not hypotensive, they look well, it's an isolated injury, right? Versus the guy who's been ejected from a vehicle, does deformed extremities, funny looking chest, and is talking out of his head. So sick is, the folks that you're concerned about, holy crap, they may die soon. That's what we mean by that. If you have a patient who has a mechanism of injury and any kind of abnormal physical finding and they look ill, you start moving toward the trauma system, right? So y'all go south, that's a popping place. So that first picture she showed the guy with the impaled foreign body, right? So the way I would manage that in my mind is, I walk on scene, I see that guy, I know he's not staying here, I know I can't fix him. And he's talking to me, hey man, I'm Dr. Ferguson, this gets you up to start moving to the stretcher. You get them up, stabilize, sit them down, maybe some vocal dressing as you move to the hospital. I'm talking, getting the histories, I'm getting IV access. I'm thinking in my mind, if he decompensates whatsoever, I'm hanging TXA. I'm already on the phone with TCC to make sure back to sound has a spot for him, or I gotta fly the guy somewhere, right? So trauma patients, you assess, you treat as you move, because you can't fix that, right? Medical, you stay in play, that's the STEMI or stroke, which is not dependent as well. Talking about pneumothoraxes, so people always get caught up on tracheal deviation and his breath sounds, and that's important. But I think more important is recognizing the mechanism that causes a pneumothorax. So dude shot in the chest, probably has a pneumothorax. So your next question is, does it need to be decompressed? Does he have signs of tension? And that's going to be poor perfusion, which is low blood pressure and altered mental status, or cardiac arrest. Okay? The medical patients can get tension pneumothorax, like you said as well. So if I got a 60-year-old female, cardiac arrest, we do CPR for 8 minutes, defibrillator, intubator, we get her back, she's got a great pulse, I'm bagging her. Now all of a sudden she's hard to bag, her stats drop, and I lose her pulse, and I got no breath sounds on the right. What's going on with her? Tension pneumothorax with CPR. So if she's got risk for pneumothorax, right? And now she has signs of tension, she gets decompressed as well. So it's a relatively easy thing. There was a GSW that came to the front door not long ago at UAB, shot in the shoulder. So I'm rolling back in a wheelchair. He's diaphoretic, talking to me. He gets kind of altered. We put him in the bed. He's not moving. He's shot in the shoulder. He gets popped, needle in the chest right then. So I don't have him to monitor. I know he has no radial pulse. Now he's altered, signs of pneumothorax. I'm going to decompress his chest. If we manage the airway, start IV access, hang the TXA, and call for a surgeon. Does that make sense?
So I think this is, I have to mention this, because I've got a few texts about it. So people want to hear the opinion of Dr. Rose and Dr. Ferguson on field treatment of flail chest segment, bulky dressings, or internal splinting with intubation and positive pressure ventilation, because those seem to be opposing views of emergency treatment, and they're both endorsed by different internationally known associations. I really don't think it matters, because I don't think either one of them works, but I'd like to hear what y'all think.
Yeah, so classically, like when I first went through like EMT and medic school, we was taught bulky dressings. That's how it was like back in the day. But ABCs always come first, right? So if you've got somebody where they're to the point that the flail chest in itself, it's a problem. Obviously, you know, it affects the excursion of the lungs. That in and of itself, though, isn't a problem. The problem is what it causes after. So when I start to see the tension, if they're not breathing for whatever, my ABCs are always going to come as a priority for that. And in those patients, I'm not going to hesitate to put them partially down and intubate them.
So do you think somebody with a flail chest, are they high risk for a pneumothorax? Yes or no?
Yes.
Yes. So if they're altered and hypotensive, you decompress that chest, right? Because they may have a tension. The state also says in our protocols that you can decompress a flail segment if you're going to intubate them. And why is that? You bag them or you intubate them, you got positive pressure, you know they got a pneumothorax because they got a flail segment, busted ribs. It's going to get worse when you bag them. So those guys get a decompression as well, all right? I'm not a big fan of putting bulky dressings, things like that on people. If you try to put an ACE wrap or a bulky dressing on me or a sandbag on my chest, even on a normal healthy day, I'm not going to breathe well. So you manage them, like you said, ABC. So they'll get high flow O2, IV access. If I'm concerned for hemorrhage, they get TXA. If they become altered, drop the blood pressure, they have a flail segment, I'm concerned for tension pneumothorax, I'm going to decompress that chest, and I'm doing all this as I move toward the hospital. The way we manage flail segments in the hospital is they get intubated, we manage the airway, we put chest tubes in them, we control the pain. Young, healthy people who have isolated flail chest and no other underlying injury, sometimes you can go in and do a nerve block so the pain goes away and they do fine. But how many people do you see get a flail chest and don't have EO injury? Not many, right? So the other things to be concerned about with that. So, yes, sir.
If you just wanted to use something with a saline bag, be a good option.
Yeah, you could, if you wanted to. I mean, like the video that she was trying to show you earlier, y'all probably seen that on YouTube before. That dude's chest was moving like crazy. You could, in reality, for that guy, I'm probably gonna decompress his chest, give him some sedation or pain control, high flow O2, and move toward the hospital. So I would routinely don't recommend putting anything on those things.
And nobody, if you've got in the field any concern for tension, like if you've got somebody and they have like suspicious, trauma, and they've got any of the, red flag signs that there's something wrong, nobody in the trauma bay is going to fault you for decompressing if you've got, reason for it. Because it's either way, if they have no lung sounds on that one. So several things are going to happen is, one, it was just like, really badly loud and you couldn't really hear the lung sounds, and they were hypotensive for another reason or other. And then maybe they get like a little trace pneumo from the actual like decompression itself. I mean, we'll put a chest tube in, but I'd much rather put a chest tube in that than you guys have to second guess and be like, is this really a tension? If you've got concern, if their blood pressure is low, if they, you're not picking up a blood pressure whatsoever and they just look terrible, if for some reason they arrest and, you don't have any other obvious signs for why they are arresting, like, no obvious other trauma, nobody is going to fault you for decompressing because it can save a life.
Right. So when you decompress somebody's chest, you should not be concerned that the patient's going to call you names. If the patient is cussing at you and calling you names, okay, unless you gave ketamine, they should not be doing that, right? They should be altered and signs of perfusion, or they should be dead, right? So if you're looking at that guy, he's breathing 4 times a minute, he's breathing down, he's got chest trauma, you decompress that chest. So if you can tell the state he had a pneumothorax and signs of tension, you're covered. Okay. And like she said, there's limited risk for that. Okay. The mistakes I've seen people have these folks who have COPD, they're hypoxic, their sats low, they got diminished breath sounds, and they decompress it, they have a pneumothorax. And that doesn't fix it. We decompress for a tension pneumothorax, all right? Because the tension is what kills people. So, remember, flail segments, sometimes they're really hard to see in the field because if you break these ribs on young, healthy people, the muscle spasms. And then so when you got your hands on their chest, you're doing a quick survey over a couple of seconds, you feel some crepitus, but it's not really asymmetric yet. But you give that dude an hour, hour and a half later, that muscle wears out, then you can see the movement changes. So sometimes you can feel that sub-Q air, feel the crepitus, and don't see the asymmetry right off the bat in the field. Okay.
It's great. Great lecture, Dr. Ruddick. Really appreciate it. As always, thanks, Dr. Ferguson. For those of you online, there's a link in the chat box to fill out the attendance form. If you can't access the chat box on your device, for whatever reason, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the attendance form. The password that's required on the attendance form for the lecture today is the word thorax, THORAX, all lowercase, and you'll get your certificate as you fill that out. Please fill out a certificate, everybody, both live and online, even if you don't need the content. It helps us find out who we're reaching and gives us an idea of what we can do to do better. Please be honest on the feedback. We definitely read all that, take it seriously, and make changes based on it. Thanks everybody for participating. We'll be back in 2 weeks, actually 3 weeks, in 3 weeks on the second Wednesday of April, right? At Centerpoint Fire. And then in the fourth Wednesday of April, I'm actually not sure where we're going to be. We're in Decatur. I think we're going up north, closer to Decatur, if I'm correct. So thanks to Prattville Fire for hosting us today. Thanks to Alabama Fire College for sponsoring this, and always thanks to Dr. Ferguson and Dr. Rose. Appreciate y'all, and we'll see you next time.
I just got an email. We're going to do a cadaver lab from last week of August 17th in Birmingham. We'll post that here pretty soon. We can do chest expression and things like that.
Awesome.
Thank you, Dr. Rose.
Welcome, sir.